Sweet.
Okay, thanks. Also, congratulations on all of the R01
Thank you.
and all of that. Congrats. All right, it's our pleasure today to have Dr. Devan Jaganath here, assistant professor in Peds and Division of ID. He studies tuberculosis in pediatrics and has done a multitude of work, including international Delphi consensus process, and has done some really exciting work with TB diagnostics in kids. So we're really excited to hear what you're going to teach us about this year.
Thank you. And yeah, thanks for inviting me again, Teresa. And it's always fun to connect with others in the pediatric global health field and those that are starting their career and seeing what it's like. Let's do it. Good.
Looks
Great.
great.
Awesome. So yeah, again, my name is David Jaganath, and it's great to be able to be back and discuss and share my interests in pediatric tuberculosis. And uh, as Teresa mentioned, one of my main passions and focus has been in how do we advance TB diagnostics for children and adolescents globally. And this year, we've put out a consensus on kind of best practices. So I thought it would be interesting as part of this year's series to maybe just kind of go through that process that we went through because it definitely was a process and took a lot of steps and years to do and just kind of talk a little bit more about what we achieved and how do you kind of get people all over the world together to address some of these complex issues. Um, so again, objectives, talk about why we went through this consensus process, describe what it was, and then ultimately kind of review results. And feel free to ask questions along the way, or we can talk about them at the end. So just to get everyone on the same page about tuberculosis, so this is an infectious disease, and TB in general is the leading infectious disease killer globally, and within children, it still plays a substantial burden. So of the almost 11 million individuals each year that develop TB, about 12% or about 1.2 million are children less than 15. But then at the same time, if we look at the mortality, even though they represent 12% of the total burden, about 200,000 or 16% of them are contributing to the mortality. And so you can see there's this disparity where they have a disproportional burden of the mortality from TB. And when we look at who those children are, a huge amount of them, really all of them, are because they didn't really get started on treatment, 96%. And then there's a large burden in young children and less than 5 and those living with HIV. And so when we think about why they're not being started on treatment, there's a somber reality, which is just that the majority of TB cases in especially young children are missing, meaning that if we look at the estimated cases, that like 1.2 million that we have, and then we look at the number of cases that are actually being reported to public health programs, only about half of children less than 5 and a little bit more than half of those 5 to 14 are not being reported. And while part of that might just be reporting challenges, but I think the real concern and the main contributor is the lack of diagnosis. And that's really a just tragedy because this is a curable disease. The kids do well if if they've been identified and started on treatment and they can, really improve rapidly. And so really improving diagnostics and improving our approach to identifying them would be really important. And at the same time, we have to recognize it's quite difficult with our current tools to diagnose TB in children. One, the standard way, especially for pulmonary tuberculosis, is to get sputum, and adults and adolescents can expectorate a sample, but for young children, they're unable to really do that. And so either we induce a sample with hypertonic saline and try to get it, or we do gastric aspirates, and that's what we do often here, right, at UCSF, is we admit the child, and this is like from the training guide of how to do it. It's like you have to collect a sample, and we might hospitalize them, put a NG tube in, and collect it each morning, and that's our current standard, which
Thank you.
is really sad for a disease that's been around for so long. And at the same time, even if you get that sample, the performance of the test is pretty poor compared to adults, because children tend to not form big cavities in their lungs, and so the amount of bacteria that we see in the sputum tends to be quite low. And so as a consequence, when we have tests that are either a smear or a culture or even a molecular PCR test, that the sensitivity, as we see here, is really suboptimal. And so we're still, even if we get a sample, which you can imagine is invasive, requires infrastructure, hard to implement in a primary care setting, like even then the test is not going to perform as we would want it to. And so, from a development standpoint, what are the needs? What would be helpful to improve TB diagnosis? And this has been pretty well defined. We want them to be more sensitive, not being sputum based. We want that, to be able to evaluate not just pulmonary TB, but there's children tend to have a higher proportion of TB in other places like lymph nodes or meningitis. And so having tests for them would be important, being non-invasive, not requiring a lot of volume for testing, especially for blood, maintaining privacy and confidentiality, especially for adolescents, and then really making sure it's important for our, most vulnerable groups of children. And this has, again, been pretty well defined through target product profiles. This actually came out yesterday, a new one just on tuberculosis diagnosis, detection, and for resistance. And then also just to highlight that the approach for evaluating these TB diagnostics is also fairly well defined to that we've put out articles and consensus documents over the last decade that describe how reference standards should be created and how the study should be performed and the key analyses. So, we have both the needs and we have the approach. However, there's still a large delays in providing access to new diagnostics for children. And just as a couple examples, so expert MTB riff, some may be familiar with this, is a test that was developed by Cepheid, which is nearby in Sunnyvale. And I would say PCR testing in general, and then expert in particular, have really revolutionized TB testing globally, where we could implement in more peripheral settings PCR tests and have a result in 90 minutes has really been really a great contribution to global TB. But when we look at the history of it, it was endorsed in 2010. And when it was first endorsed, it just was for adults because there wasn't data in children. There eventually was data published a year after that, in 2011. And then it was only endorsed by the WHO, both for children and then for extrapulmonary TB, which again is relevant for children, 4 years later in 2014. So you can imagine, there's this test that clearly could be quite beneficial for children, but there was neither data nor really endorsement or support to implement it in children for 4 years. And think about, the lives lost and the delays that occurred because of that. As a more modern example, there's been a variety of AI tools now for TB. One is computer-aided detection, or CAD, which is able to look at X-rays automatically and highlight areas of concern and can be used for TB screening. And these have really developed quite a bit over the last few years. And in 2021, the WHO endorsed it as a TB screening and triage tool for adults only. And the simple truth is just that there's no validated algorithms for children. So again, we're now quickly approaching 2025, and there are no tools or tests that are available for children in this space. So just to highlight then that, they're clear, children and adolescents are being neglected throughout this diagnostic pipeline. They're rarely considered in the early design process. They're not really included in the early evaluation. And for adolescents, that's even more unfortunate because they tend to have more adult-like disease. And so, and they can expectorate sputum. And so you imagine that they would be nice for them to be included, but they're often enrolled in pediatric studies because they're less than 18 and they might be part of pediatric clinics. And so they often are not part of it or in limited numbers. And then oftentimes, once, as we saw with expert and plenty of other examples, the evaluation in children usually occurs only after these adult studies have been done, after and frequently after it's already gone through a regulatory approval process. And then the thought is, well, let's try it in children and see if it works. And so what are the consequences? You know, the tests are not really useful or feasible for children and adolescents. There's clearly delays in approval for these tests for them. And then from a provider standpoint, you know, it's leaving an individual with the difficult choice of having to decide whether to not utilize that test because it's not approved for children, or to utilize it without the data or guidance on best practices for it. So really there's a gap there. And you know, but and why are adult TV studies prioritized? I think there are some, it's important to recognize that there are some good and important reasons to consider. I mean, I think adult TB in general has clear reference definitions because, again, the molecular and culture-based testing is more reliable than in children who are often diagnosed clinically with negative kind of gold standard tests. The samples are easier to collect. They can collect larger volumes, again, of maybe blood, which is useful early on when you're doing iterative testing. Can be cheaper and faster to enroll adults. You know, the burden globally of TB is majority in adults, so you can enroll a lot faster. And again, usually just need like a baseline evaluation. And then at the same time, it's important for us to recognize that there are ethical considerations because we want to reduce the harm on this vulnerable population in children. And so, you know, this is kind of fundamentally kind of an ethical balance, right, of the benefits and risks of including children. So there's clear benefits and greater inclusivity, that we can address their unique needs, having earlier assessment approvals and trying to get it implemented and increased access as quickly as possible. But it's important to recognize the potential risks. You know, if we're thinking about all tests currently and maybe in the future, you know, we don't necessarily want to expose children unnecessarily to invasive tests. That getting samples can be more challenging and in smaller volumes. And so, you know, being able to be thoughtful about when and how to use them can be useful. And again, you know, if we're just starting with a new test, maybe it can be difficult when we're trying to interpret whether it's useful or not if the gold standard and the reference definitions that we have for children and adolescents are maybe not as clear cut. So, you know, I think clearly this highlights that while we have kind of an understanding of that it's important to have these diagnostics, and at the same time that, you know, we have the tools to evaluate it. The implementation of actually how to go about this, you know, when and how to best include them when they're developing or evaluating diagnostics is really not well defined. And as I highlighted, it's really, we have to think about the potential benefits while balancing against the risks. And recognize, even as an advocate for children, that, you know, some tests may not be appropriate to include in children early. And then lastly, and most importantly, just that, you know, every perception might be different depending on the stakeholder. So a developer or a researcher or a funder, the patient, the caregiver, the provider, everyone kind of might view these benefits and risks slightly differently. And so that's really where a consensus could be valuable, to really get everyone together and think about what's the best approach. And so that really was our main objective. So how can we achieve a consensus from these diverse stakeholders on what's the best practices to guide the inclusion of children and adolescents in both development and evaluation of new diagnostic tests for TB. And you know, and so we completed this, and just as I think Tiffany sent this off to the pathway residents, but this paper came out in Lancet Infectious Diseases just a little more than a month ago, and really highlights the culmination of several years of work in achieving this process. So we'll just kind of move on to what that process was. And so, first, in we started this in 2021, just to give again the highlight of how long it kind of took. And the it just started off as an idea that, this was a challenge. And again, personally, I was finding both that I was seeing these gaps in access and delays, but at the same time, really kind of struggling to understand what was the best approach and when to kind of best include them and when to advocate for their earlier inclusion, whether versus kind of first having some initial studies and how to best communicate that. So the first step was just like, how do you get people together that are experts in this field to kind of think through this and see like whether this is something we should pursue. And so we built this core working group, and this was the working group, and my main partner was Elsa Bishker, who is a pediatrician based at Oxford, and she's part of a large consortium of called the FEN consortium that looks at TB diagnostics. I was part of another consortium also supported by the NIH called R2D2, and then there was a third one called NDX, and we were all kind of dealing with similar questions and issues, and so we thought that this would be valuable, and then we brought together a wide range of real experts in pediatric TB to be able to kind of help us think through what are the core issues, how can we approach a consensus in a thoughtful way, and kind of help guide, what those statements would be in the process and its interpretation. So once we had that, then we had to identify the individuals who actually participate in the consensus process. And so to that extent, we wanted to have a diverse group of stakeholders, again, not just academia and also within academia, not just pediatric focused, but those that kind of ran the spectrum, and also have industry, nonprofits, government advocates, those are regulators, and multilateral organizations, those that, are in the space and may have different opinions. And so with the working group, we, identified potential participants based on expertise and trying to have some geographic representation and trying to have, representation from TB endemic settings. And so ultimately we invited a wide array of people, and then in terms of those that agreed, we had a total of 42, still with kind of a majority from the child TB space, but as you can see here, kind of a mixture of other groups. And then, in thinking about how to develop the statements, I think in thinking about there were a couple approaches one could have. One, you could just develop the statements based on what you think, or you could have initially a qualitative round. And so I think we felt that we should have a more open-ended qualitative round in order to really kind of see what would be the main issues and themes and statements that we could form. And so initially we kind of developed some open-ended questions around the issue. We piloted it, then we adjusted it, and then we distributed it to all these participants. And we use this website called Wealthy, which allows it to be anonymous, which is nice, and allows everyone to kind of have an equal weight and contribution. And so based on that, we were able to kind of identify key themes. And then once we had those themes, we had to coalesce those themes into statements. And then we had to have quantitative rounds in which the participants could vote on whether they agreed or disagreed on these statements based on a 5-point Likert scale. And if they disagreed or they had any comments, they could, always enter it. And then if we didn't have a consensus, as I'll mention next, they could actually look at what others had written about a given statement anonymously in order to kind of potentially change or adjust their opinion. And so we define consensus as having at least 75% of either agree or mostly agree. So then, we had a first round. We did have to adjust some small wording in some of the statements based on the feedback. And then we had a second round. And then ultimately we had about 20 consensus statements, as I mentioned. And then because it was only 42 individuals ultimately, and we wanted to make sure that we had a wider array of feedback, not just from those spheres, but have it as open as possible, include advocacy groups, others. We did have a dissemination kind of public webinar supported by the National Allergy and Infectious Disease Institute, NIAID, in order to really kind of make sure we were including as many people as possible in the discussion. So that was the process. And again, we just tried to be as thoughtful as possible and really try to include as many people as possible so that we can really achieve consensus. So let's jump to the results. So in terms of qualitative round, we had really some core themes that emerged around different issues, as we'll go in some detail. So one is just people highlighted the child-specific factors and characteristics that were important for diagnostics that were unique. So kind of as I highlighted before from the target product profile, one participant highlighted that it should be non-invasive, require minimal samples and non-sputum, and really somewhat easy to collect, and really should be more sensitive for some of these markers in order to capture more children. In terms of stakeholder involvement, stakeholders meaning kind of children, adolescents, caregivers, and potentially providers. I think that was another kind of major theme. And in an example, someone highlighted the importance of getting early qualitative data and acceptability of tests using different sample types, and in order to assess the preferences of children and caregivers, which are necessary for the design and development of diagnostics for children and adolescents. So really highlighting the importance of getting their preferences and opinions as early as possible. In terms of the timing of diagnostics, I think we had an array of opinions, which was really great, and I think spoke to the importance of having a consensus. And so when timing, I mean kind of at the same time as adult studies or sequentially. And for example, in one opinion, someone recognized that it might be more efficient to first look at it in adults and then adapt it to children. But then they also recognize that it might lead to worse performance in children if it's not being kind of tailored to that population. But then they also said, it would reduce cost, sample size, and time. But then conversely, someone really highlighted that children have a different immune system. They have, especially young children, have a developing immune system, and we know that their response to tuberculosis is different than an adult. And so, just as I highlighted there, I think they made the point that host-based tests should be developed in children from the start, just recognizing that you can't necessarily take a biomarker, for example, for adults based on an immune response and assume it's going to work as well in children. In terms of the inclusion of adolescents potentially in those adult studies, again, recognizing they have adult-like disease, I think, again, we had an interesting kind of array of opinions. So this person noted that, that they should be included, but then also noted that that there should be a clear kind of analysis plan for them in those studies, because sometimes trials and other studies may say, like, we include adolescents, but they don't necessarily include enough in order to have a core opinion related to that population. But then at the same time, I think people, made the point that, if we can define adolescence as 10 to 19, which is what the WHO defines it as, they recognize that that's a very kind of heterogeneous group, essentially, where young adolescents might be closer to the younger population, older ones may be closer to the adult population. And so, they weren't necessarily, say as on board of saying every adolescent should be in adult study. And then another theme came around just recognizing the importance of algorithms and combinations of tests that, and traditionally we test diagnostics kind of one at a time and just say, how is it accurate for that one test? But, the reality is that, they, from an implementation standpoint, are being utilized as part of clinical algorithms or in combination of other tests, and that we should kind of shift our perspective to looking at that. In terms of reference standards, this is again, a big topic of discussion in childhood TB because the gold standard tests are not perfect. And so this person just highlighted, that maybe we should be considering the stage of development, early on when there's clear case definitions. Maybe we should only be including children that have, cleared microbiological confirmation that they have TB. And then if there is utility, then moving to those that maybe are more clinically diagnosed, just recognizing that that population is important, but it also makes interpretation early on challenging. So again, these were the variety of themes. And so then we had to take these themes, craft them into draft statements with the working group, and then move to these quantitative rounds. And then, so we'll go through these quantitative rounds, then we'll describe, what are these final statements. So ultimately, we developed 20 statements as drafts, and we kind of tried to think of more novel statements, not ones that were part of other guidance documents. We had 2 quantitative rounds, which had quite high response rates. In the first round, we were able to get 13 statements that achieved consensus, and then after adjustment, we were able to get the remaining 7. And then we had one kind of as kind of a secondary statement that we had crafted based on the feedback on the first round, but that didn't achieve consensus. It almost did, but not quite. So the way that we organize these statements is by the different stages of development and evaluation for diagnostic tests, and I'll just go through that in detail, and then we'll go to those statements. So for test development, this is the steps to create that diagnostic, and so it includes the initial needs assessment, concept design, feasibility testing, and prototype development and optimization. So in terms of those statements, and again, the paper that we sent out, or we can send out later, are, I'll go into, you can read that at your own time, and so I'll move through these fairly quickly and just highlight some of the key themes. But similar to what we heard from the qualitative work and also past TPPs, is really the importance of minimum specimen volume. I think developing new tests, with non-sputum samples for both pulmonary and extrapulmonary TB, and then taking tests that have been initially developed for sputum and really trying to evaluate them in parallel for their utility in non-sputum sample types. So again, trying to meet the needs of children in particular. One thing that came out from an analytical consideration that again, I think balanced and recognized some of the challenges for pediatric samples, that when there's assay optimization for a new pathogen-based test, so just trying to detect that TB bacteria or the bacterial DNA, that there could be value, and it makes sense to start with adolescents and adults, because at that point it's not really related to their immune system. We're just trying to detect the, again, mycobacteria, and and at the same time, they might have more samples and clear reference definitions. And so at this early optimization stage, for this type of test, it makes sense to utilize adolescent and adults. But again, doesn't apply to host-based tests. And at the same time, people recognize that that we should be thinking about stratifying the test by the amount of bacterial burden that they have, recognizing that children have lower bacterial burden, as I mentioned earlier, and so we can at least get some initial signal that it might be valuable in children. There was high agreement, and as highlighted through the qualitative statements, that really getting feedback from children, adolescents, and their caregivers should be incorporated throughout the process, and that they should collaborate with developers, that researchers should collaborate with developers to help facilitate their connection to both the participants, but also data and samples. And just again, really highlight that early stage, this is from one participant, that early stage evaluation should make at least some assessment of the acceptability and usability of a diagnostic for children and adolescents, so that design modifications can be where did I lost myself? Design can be made early and the product can stay on the critical path to commercialization. If this is not done until late stage, the investment may be wasted and developers may need to go back and repeat development steps. So really the importance of including them as early as possible. Moving to early evaluation. So this is just, we've got a test and now it has been design locked. So they've kind of made it to what it's going to be, and we're just trying to get an early sense of its accuracy against a gold standard. So going back to the inclusion of adolescents, we were able to get consensus that adolescents should be included in adult TB studies, and at the same time have a specific analysis for them. And just really to reiterate that there was variation, it's in their inclusion. I think they highlighted that they can expectorate, they have a closer clinical presentation to adult TB, and that it really could help get more data for adolescents because there's just way more studies in adults, and really could get the data more quickly. And at the same time, though, people thought maybe they should be in separate studies because they maybe are unique to both children and adults. And then others, like I mentioned before, recognize that maybe younger children are closer to younger adolescents are closer to children in terms of their challenges and needs. So I think ultimately what we highlighted, we're able to get consensus on is, yes, we should include them in adult studies, but it doesn't preclude still doing either adolescent specific studies or including them in pediatric studies. But this is a way to accelerate the data that's available to that population. In terms of thinking about the test type, so for pathogen-based tests, again, trying to just detect the bacteria, we had really a range of responses about whether to include children in parallel to adolescents and adults or do it sequentially, because again, similar to the early optimization that, people just said, does it really matter whether it's a child or an adult, and we're just trying to detect it. Other people made the point like that's what creates delays if we don't have that data. And so ultimately we reached consensus actually based on thinking about the risk of actually collecting or performing that test. And so if it's a pathogen-based test in early evaluation, if it is greater than minimal risk, then it makes sense to first evaluate that in adults or in adolescents. If it's minimal risk, though, then it should be evaluated in children in parallel to adolescents and adults. And if it's performed first in adults, then it should be initiated in children as soon as it's shown to be promising. And again, just to highlight that there really was a variation in opinions, again, highlighting that there really was a need for doing this consensus process because, the opinions varied from so again, someone highlighting that going through this enrollment of children can be challenging and expensive, and that at the end of the day, we're just trying to detect the bacteria, so it doesn't really matter if it's an adult or a child. But then another person made the point that like our thresholds for what is valuable might be different for adults versus children, saying that a test that's no better than an existing test for adults might be incrementally or even significantly better for children. So the importance of including them. And then again, just highlighting the importance to develop tools specifically for children. And they said, if we only adapt diagnostics from adults, we'll likely continue in this cycle of having tests with insufficient accuracy among children with polyvascular disease. So, a range of advocates on both sides. Conversely, though, when we talk about, immune-based tests or host-based tests or even digital diagnostics, I think there's a recognition that children and adults are different, both in how they present and in their immune system. And so there was clear consensus that these tests should be evaluated in parallel, in both for host-based biomarkers and for digital health tools. At the same time, thinking about going back to that challenge that people mentioned, that it might be expensive to do the enrollment, take a long time, and at an early evaluation stage, we're really just trying to get a sense of whether there's some accuracy signal. I think we were able to achieve consensus to highlight that at this stage, then there might be a real value in focusing on bank samples for children. They're already collected, they're already defined, and that way they can be brought in earlier and kind of overcome some of those barriers that people highlighted. So we, achieve consensus on that. And, as someone noted, it's important to use these samples to provide initial data on performance, and but recognizing that, not every sample type may be amenable to this, and if that's the case, then we need to do prospective testing. In terms of the analysis, I think, again, people were a little concerned about the gray zone of clinical diagnosis in children. And so we were able to achieve consensus that at a minimum, we should be focusing on those that have clear microbiologically confirmed TB, and then those that are symptomatic but without TB, which we defined as unlikely TB in our field. But that unconfirmed group of clinically diagnosed children, that while we didn't get consensus that they should be definitely included with this, there was recognition that early testing should be done soon after. All right, and then now the kind of last section is on late stage evaluation, which, is now it's already been design locked. We have early signal that it seems like it's promising, and now we're trying to assess this in a wider population where the test would actually be performed. So going back to utilizing stored versus prospective samples, there was large consensus that at this stage, we really should be thinking about prospectively collecting and testing these children in the field, and at the same time contributing to a biobank that could be used for more early evaluation. We should be using clear reference standards based on our consensus definitions. And now this is where really including those clinically diagnosed unconfirmed children, either in a microbiological or a composite reference standard, is important, because they really represent a bulk of the TB disease in children. And then lastly, as I mentioned earlier, there really was strong ideas around really thinking beyond kind of the single test accuracy and looking more at other components, whether it's added yield, and looking at how it might perform in combination with other tests and clinical algorithms. I won't do that for time. So kind of how did we pull this all together? So just as we created this figure to kind of help guide people as they think through this process. So if it's a pathogen-based test, again, what's the risk of performing this or collecting it? If it's greater than minimal, start in adults and adolescents, then a promising move to children. However, if it's minimal, or if it's a host-based test, we should be doing testing in children in parallel to adults and adolescents, both as an early and then a late, and then we can move. And then the goal then is, then when you're actually looking at implementation studies, we can actually do that for all groups, regardless of their age. And then throughout the process, we should be involving children, caregivers, adolescents, their providers, in order to ensure that we're meeting their needs. And just as an example, so in the TB space now, there's been a lot of work in oral swab testing, building off the work that was done in COVID, in order to now say, can we use oral swabs for molecular TB testing? And so if we use that as an example, it's a pathogen-based test because it's just like a PCR, you're trying to detect TB. And so early optimization could be done with adults and adolescent samples, because again, we're just trying to see if we can actually detect on the swab the mycobacterial DNA. We could stratify that though by bacterial load in order to see if it's valuable in children. And then if it's promising and we go to an evaluation stage, if we go through this algorithm, it's pathogen based, but the oral swab is a very minimal risk and it's easy to collect. And clearly there's a value in children because it would provide a non-invasive way to collect a respiratory specimen. So that's where we'd move down into this category. And this is what we're doing. We're looking at swab tests in parallel to adults and adolescents in our cohorts. And so that allows them now to be much earlier, because again, just to recognize that before this, children would be kind of in this area, kind of, I don't know if you can see my pointer, but it's, below the demonstration stage. So, some strengths and limitations. I think we tried our best to really invite a range of stakeholders, though, there was some skew towards certain groups and, and populations and settings. And so I think as a next step, we really are hoping to engage more with patients, and we didn't include patients and caregivers as part of this, but, how can we engage more with community advisory boards and work to disseminate more of this through local kind of public health and other groups. I think the qualitative round was really valuable in informing these statements and making sure that people's voices were heard. And I think that's how we were able to get consensus relatively quickly. We couldn't consider every diagnostic. There's always going to be something exciting and new, which is important. And so this is really just meant to be a general approach to making decisions and communicating, and also recognizing that this is an iterative process, and that, this hopefully is a framework to communicate with others, whether it's developers or other researchers, and say when and how can we include children, when does it make sense, and have that conversation as early as possible. And then, while we didn't focus as much on future implementation studies, you can imagine similar considerations could be made. And then again, if this work has been done, hopefully around the same time, both tests would be available to work on all ages. So in conclusion, and then we have, I think, time to chat, is really, we tried to get together all these different stakeholders, and we were able to get consensus that the needs and feedback of children, adolescents, and caregivers should be included throughout the diagnostic development and evaluation process, that we can utilize either well-characterized bank samples or prospective enrollment of children and adolescents, and they should be included as early as possible. But we should be considering the type of tests and the potential risks. And, when we're doing these analysis, we should be using standard consensus definitions and considering how we can integrate them into existing algorithms and other tests. And so, again, I just want to recognize the working group members and really the participants who really brought this together and brought their expertise and experience. So, and our funders at NIAID. So with that, thank you so much. Look forward to any questions or discussion.
Thank you so much. Let's open up to questions. If you can't come off mute, feel free to put it in the chat. I just also want to say, having done some of this consensus building work, it is an enormous amount of effort. So congratulations on trying to get all of these experts to align. It sounds, I mean, having lived it, it's quite an accomplishment. So
thank you. Yeah, but it was, I mean, it really has I think paid off, because I think one thing that's been nice now moving forward is you have everyone's buy-in, because invariably it all sounds nice, but then once there's actually a test and you're actually trying to make decisions around like when to implement it and you're talking to either companies again or you're talking to these groups, and if you can have a document and you can say you are part of this consensus process, and agree to this kind of approach, it does, I think, really help with the communication, because it sometimes is too easy and it's ineffective to say children are vulnerable and they need things, right? But actually having a clear cut approach, I think, is useful.
Because we have a few extra minutes, would you mind just giving kind of like a brief overview of your like global health career? We have a lot of trainees on the call, and it's kind of nice to hear how everyone's path is a little bit different.
Yeah, sure. So, I started getting interested in global health in med school. I went to med school at UCLA and had really great mentors and support to kind of, get some early experiences and initially in kind of qualitative HIV work. And then I was I kind of thought, okay, this might be something I want to do, but I didn't really have a lot of experience. So I took 2 years off of med school and I did a Fogarty year and I lived in Uganda for that year in Kampala. And that's where I had one project on childhood TB and really became interested in that topic at that point, or at least starting to get interested. And then the second year, I did an MPH at Johns Hopkins and kind of got more interested and focused on epi and kind of biostats work. And then went back, finished med school, and then went back to Hopkins to do my peds residency. And that, they also at Hopkins really had a big TB kind of focus and a lot of great mentors and support there. And so um, that's where again I just got more interested in the field and seeing that come together, and I became interested in pediatric infectious diseases and residency. And so then I came to UCSF for a fellowship and just kind of kept going and was able to have great mentors that allowed me to kind of pursue this as a career, and I think there's a lot of different trajectories of what global health means. I think, as everyone knows, everyone has different interests and focus, whether it's clinical care or programmatic work or policy or whatever. And, for me, I was more kind of on the path of the kind of traditional research kind of pathway of kind of doing doing academic research projects and writing grants and all that good stuff. And so I was able to really have good mentors here to kind of help me with that and build kind of this network and connect to the field. And so that's just kind of allowed me to kind of have that path. Yeah, the more kind of KR kind of NIH funded kind of path has been my global health space.
Any advice for trainees interested in a global health career?
Yeah, I mean, I think the theme I maybe highlighted is twofold. I mean, one, I think it's important to take advantage of experiences. One, for obviously your interest in global health, but also like actually asking the question whether you want to do it and what it entails, and really understanding that spectrum, right? Because again, global health really runs the gamut of things and they're all interesting and great in different ways. And so I would early on kind of just try to expose yourself to different career paths even within global health and say, okay, is this the right fit for me? And then if it is the right fit, then identify mentors that did that career path and kind of could help provide opportunities and connect you to the kind of right approach. Because yeah, I think that's really what was valuable for me is, being able to get exposed early and then finding and being fortunate to have the right mentors to support me. And if you're interested in TB, you can reach out, of course. We have at UCSF, at the Center for UCSF is a major TB hub, and we have the Center for TB, and then within that, I lead the Maternal and Child TB initiative, and so a big part of that is how we can support people that are interested in pursuing careers, either clinically, public health, research in maternal and child TB. So if you're interested in that, there's a lot of resources, and I can put probably in the chat the website if people want to just learn more about it.
Yeah, that's helpful. Thank you. We also put in the chat a survey link for those who have attended. We really do appreciate your feedback. If you could just take a minute and complete that. And any questions from those online? Okay, I think we'll get a few minutes back. Thank you so much for joining us. Good to have you back as part of the series.
Of course. Thanks all. Bye.
Bye.